Cardiovascular Psychology. Cardiovascular psychology is the study of the circulatory system. More especially, it addresses the psychology of the heart, cardio, and blood vessel vascular. These subjects are sometimes addressed separately under the names cardiac psychology and circulatory psychology.
Pumps out blood. So, just recapping, this is our heart. As we all know, the heart works like a pump, which pumps blood around the body. Let's have a closer look at the heart and the circulation of the blood coming to and from the heart. First of all, we'll look at a cross-sectional view of the heart. The heart consists of 4 chambers, if you remember. The right atrium, the right ventricle, the left atrium, and the left ventricle. These 4 chambers are important because blood passes through them within the heart. The ventricles are important because the ventricles are the one which essentially pumps blood out of the heart, and so they need to be strong. And so they contain most of the cardiac muscle cells, here in black. After oxygen has been used by the body tissues, the blood supply will be deoxygenated. It will be in low oxygen and it will have higher concentrations of carbon dioxide. This deoxygenated blood supply will then travel back into the heart through the vena cava, and it will enter into the right atrium. The blood will then go into the right ventricle. The right ventricle will then pump out the blood through the pulmonary artery towards the lungs, where it will be reoxygenated. So now the blood supply has oxygen in it. This reoxygenated blood supply will travel through the pulmonary vein back towards the heart and enter the left atrium. The left ventricle, which contains most of the cardiac muscle cells, will then pump this oxygenated rich blood through the aorta towards the rest of the body, to other body tissues. And so this circulation continues. The circulation from the heart, between the heart and the lungs, is known as a pulmonary circulation, and between the heart and the body tissues is known as a systemic circulation. Now, in order for the heart to eject blood, or pump blood out, there is contraction of cardiac muscles, and this is triggered by action potentials. So let's have a look at the cardiac muscle cells. The cardiac muscle cells are different from the smooth muscles or the skeletal muscles, but they have some similarities. For example, the cardiac muscles are also striated, like the skeletal muscles. They contain 1 nucleus per cell, usually, so they're mononucleated, and it looks something like this. This is a magnified view. Another important feature cardiac muscles possess that differs it from skeletal muscle, for example, is that they have intercalated discs, junctions which separate each cardiac muscle cell. And these intercalated discs, these allow the cardiac muscle cells to contract in unison. So if one cardiac muscle cells contract, all cardiac muscle cells contract. And this is important to pump blood in unison around the body. Also, cardiac muscle cells contain T tubules and sarcoplasmic reticulum for calcium release. And so therefore calcium, as we know, is very important for muscle contraction. Now,
Applications in medicine. Powerhead AAD-G3 Plus is a flagship cardiac sciences automated external defibrillator that features squad-ready liquid coach and start bypassing technology to make your quick and simple as possible available in automatic and semi-automatic models. This IAD is ideal for light response to use in public access defibrillation areas such as schools, athletic fields, and workplace environments. Features include risk-ready technology that self-checks main AAD components, battery, hardware, software, and daily. The IAD completes a partial charge of the high voltage electronics weekly and a full charge monthly. Easy of use, clear voice prompts and helpful. The screen guide the user through the entire rescue operation.
It happens in a heartbeat, sudden cardiac arrest, claiming thousands of lives each year in Hong Kong alone. Without immediate intervention, only 1% will survive. The earlier you give CPR, the better the survival chance. But CPR is not the only answer. Only a defibrillation shock can reset the heart to normal rhythm if administered in under 5 minutes. When you come across someone that has collapsed, first see if he or she can respond and is conscious. Then check if the patient is breathing. If he isn't, get your friend to call 999 and run to find the nearest AED. Remember, every minute counts. In the meantime, you should commence CPR until your friend returns. Please note, if you are alone, call 999 immediately and then leave the patient to locate the AED yourself. But be fast. Every minute counts. In summary, when you come across someone collapsed on the street, check if the scene is safe before rescue. Check the victim's response and see if they are breathing. Call the 2 A's, ambulance and AED. Start early CPR. When the AED arrives, open the lid immediately. This will switch on the AED and it will then give clear instructions. Stay calm and follow these voice instructions.
Begin by exposing patient's bare chest and torso. Remove square foil package from lid of AED. Tear open foil package across dotted line and remove pads. Next, separate one of the white pads completely from blue plastic liner.
Separate both pads from the blue liner and place them on the patient's bare chest in the positions illustrated. Make sure the pads are firmly pressed down. Please note the PowerHeart AED G3 Plus model is fully automatic. It will only deliver a shock to a patient when it is needed. You do not need to press any button, therefore you cannot accidentally shock someone. For instance, if the AED detects a positive change in the patient's heart rhythm, the AED will automatically cancel the shock.
Do not touch patient. Analyzing heart rhythm. Please wait.
Stand back from the patient and allow the AED to analyze the heart rhythm. If a shock is required, the voice will say,
Preparing shock. Move away from the patient. Shock will be delivered in 3, 2, 1. Shock delivered. It is now safe to touch the patient.
Once the shock is delivered, you will hear the following instruction.
Give patient 30 rapid compressions. Place heel of one hand on center of chest between nipples. Place heel of other hand directly on top of first hand. Lean over patient with elbows straight. Press the patient's chest down rapidly 1/3 depth of chest, then release. Start CPR. Stop compressions. Give breath. Give breath. Continue with
You
compressions.
too could help save a life with a swift, determined response to someone collapsing with sudden cardiac arrest. In summary, when you come across someone who has collapsed, is unresponsive and is not breathing, be quick. The earlier you start rescue, the higher the chance of survival. Call ambulance, send for AED and start CPR. Follow the AED's instructions until the emergency services arrive.
Advanced technology, rescue coach, and CPR. Metronomy functionality based user through chest compression in addition or proprietary path. Bypassing technology calculates electrical impedance and escalates energy to deliver therapy, and the appropriate higher level should potentially require a second shock. Assurance cardiosciences stand behind your powerhead AADS with a 7 years warranty among the longest in the industry and a 4 years full battery operational replacement warranty. Pros and cons. The primary function of the heart is to impart energy to blood in order to generate and sustain an arterial blood pressure necessary to provide adequate perfusion of organs. The heart achieves this by contracting its muscular walls around a closed chamber to generate sufficient pressure to propel blood from the cardiac chamber through the aortic bundle and into the aorta. Each time the heart beats, a volume of blood is ahead. Normal strength cardiac aura differs among individuals and different systems. Absolute the resting cardiac output of someone who behind 2 litres is unique than the cardiac output found in a person that weighs. Therefore, in clinical practice, measured values for cardiac output are often expressed as a flow per body surface area.
Circulatory system and the human heart. In this video, we will learn about the heart. The heart is an organ which beats continuously to behave as a pump for the transport of blood, which carries other substances with it. As long as a person lives, the heart works like a pump non-stop. The heart is located in the chest cavity with its lower tip slightly tilted towards the left. The heart is typically the size of a fist. There are 4 chambers in the heart. The 2 upper chambers are known as the atria or the atrium, and the 2 lower chambers are known as ventricles. The partition between the chambers helps to avoid mixing up of the blood rich in oxygen and the blood which is rich in carbon dioxide. The blood flows from the heart to the lungs and then back to the heart, from where it is pumped to the rest of the body.
Disease. Coronary artery disease. Supply blood flow to the heart, and when functioning normally, they ensure adequate oxygenation of the myocardium at all levels of cardiac activity. Constriction and dilatation of the coronary arteries, governed primarily by local regulatory mechanisms, regulate the amount of blood flow to the myocardium in a manner that matches the amount of oxygen delivered to the myocardium with the myocardial demand for oxygen.
The heart is fed by its own circulation, known as the major coronary arteries. These arteries include the left anterior descending artery, the left circumflex coronary artery, and the right coronary artery. The bloodstream contains red blood cells, which deliver oxygen to the heart muscle, known as the myocardium. It also contains fats or lipids, known as low-density lipoproteins or LDL cholesterol. Atherosclerosis begins when LDL cholesterol accumulates in the arterial wall, forming a plaque. Over time, the plaque becomes larger. Some plaques never obstruct the coronary blood flow. The patient with asymptomatic coronary disease has no chest pain and no myocardial ischemia. A plaque can enlarge to the point that the blood flow is compromised. The patient may have chest pain, but only with exertion. This syndrome is known as stable angina and is not a clinical emergency. Such a patient is still at risk for an acute life-threatening event because a plaque can suddenly rupture, causing clotting of the artery, known as coronary thrombosis. When a thrombotic occlusion is subtotal, an acute coronary syndrome develops, and there are two types. The first type is known as a non-ST segment elevation myocardial infarction, and the second type is known as unstable angina. With these syndromes, the patient experiences chest pain at rest, and the electrocardiogram shows ST segment depression. In contrast, when the thrombus completely occludes the vessel, the myocardium is injured, and the syndrome of ST segment elevation myocardial infarction develops. In summary, patients with coronary artery disease may be asymptomatic, they can have stable angina, or they can suffer an acute atherothrombotic event. Plaque rupture with coronary thrombosis is the most common cause of acute, life-threatening coronary artery disease. Emergency therapy by thrombolysis, angioplasty, or thrombectomy restores blood flow by targeting the thrombus, either dissolving it, displacing it, or removing it as quickly as possible. Rapid restoration of blood flow relieves symptoms and minimizes myocardial damage.
Heart failure is the inability of the heart to supply adequate blood flow and therefore oxygen the latter to peripheral tissues and organs. Underperfusion of organs leads to reduced exercise capacity, fatigue, and shortness of breath. It can also lead to organ dysfunction, including renal failure in some patients.
Despite ongoing advances in the management of chronic heart failure, patient outcomes for acutely decompensated disease have not improved. Across Canada, patients hospitalized for heart failure continue to suffer frequent complications, and 16.5% die during their initial hospitalization. An examination of the pathophysiology of acute decompensated heart failure identifies promising new avenues for treatment. During heart failure, the heart cannot circulate enough blood at normal cardiac filling pressures to meet the metabolic needs of the brain, kidneys, heart, and other vital organs. The body responds by releasing neurohormones. Certain neurohormones help maintain blood pressure, but over time they cause heart failure to worsen. One of these neurohormones is renin, released by the kidneys in response to decreased perfusion and increased sympathetic activity. Renin activates the renin-angiotensin-aldosterone system, or RAAS, by cleaving angiotensinogen in the liver to produce angiotensin-1, which is further converted to angiotensin-2 in the lungs. Angiotensin-2 binds to blood vessel walls, causing vasoconstriction. Angiotensin-2 also stimulates release of endothelin from endothelial cells. Angiotensin-2 and endothelin act on vascular smooth muscle, causing constriction of the coronary arteries and systemic arteries and veins. While vasoconstriction helps maintain blood pressure, it can also have maladaptive effects. For example, the weakened heart must pump harder against increased resistance in the systemic arteries, while constriction of the coronary arteries further compromises the myocardium's supply of oxygen. Venous constriction also contributes to displacement of fluid into the lungs and other tissues. Angiotensin-2 stimulates the adrenal glands to release aldosterone. Aldosterone causes the kidneys to reabsorb sodium into the bloodstream, and with it, water. Sodium and water retention cause a state of fluid overload that is exacerbated by venous constriction. Gaseous exchange in the lungs is inhibited by pulmonary edema. Build-up of fluid in and around the lungs increases the physical work of breathing. Patients with acute left-sided heart failure feel short of breath and fatigued. When right-sided heart failure occurs, fluid accumulates in the liver and legs. Apart from the activity of the RAAS, the body tries to maintain blood pressure using other mechanisms, such as releasing epinephrine from the adrenal glands and norepinephrine from sympathetic nerve endings. These catecholamines increase heart rate and contractility, in addition to causing arterial and venous constriction. Over time, chronic volume overload and the activity of angiotensin-2, aldosterone and endothelin stimulate pathologic cardiac remodeling. The interstitial fibrosis and myocyte apoptosis associated with cardiac remodeling decrease heart wall elasticity, further inhibiting the heart's ability to relax and pump effectively. In summary, the neurohormonal response to heart failure causes vasoconstriction, fluid retention, and increased heart rate and contractility. In turn, these processes initiate a vicious cycle of further myocardial injury and escalating heart failure. Fortunately, additional neurohormonal responses modulate the activity of the RAAS, endothelin, epinephrine, and norepinephrine.